Good afternoon to all of you. And first of all, I really have to congratulate the team, Dr. Saumitra, Dr. Dipankar, and Dr. Paramatha, and his team for a wonderful event that they have come up with. And I know the pains and difficulties of organizing, and I think it's a real pleasure to be here after many, many years of COVID we went through. So, a real sort of congratulations and appreciation to the team itself. So now let me come to the talk itself. So I'm going to focus on the right ventricle. So as some questions came up, and in between there were some mentions about the right ventricle itself. So it is something which, where are we in terms of quantitating and what are the issues related to it. So that's where I'm going to focus. I was just sort of looking at the PubMed itself, and if you punch in left ventricular strain, you get around 7,500 articles. And when you put in right ventricular strain, you get 6,500. So the margin is pretty close as far as the LV and RV is concerned. And when you look at the left atrial strain, it's about 3,500. It's fast catching up. So why is it that the right ventricular strain is still sort of not forefront the way GLS is? So let's see where it stands in terms of the RV itself. So a brief look at the complexity of the right ventricle itself. We have seen this many times. Just a brief overview. So you look at the chamber, it has got a inflow, and then you have an apex which is tabaculated and a smooth outflow. So, and you look at the 3D image over there, you see the shape also. It's got a shape which has got no geometry itself. So these are sort of challenges as far as the geometry of the RV itself. And when you look at the fibers themselves are different from the LV. You see more of the longitudinal fibers, that is the inner one, and less of the outer circumferential fibers. So it is thin-walled, and this is how the RV is made of. Now the quantification methods. So these are the quantification methods. So you look at TAPSE, which has been there since many decades, which we continue to use and continue to rely upon. And you have the tissue Doppler, more or less the same principle, same method, but only thing is that the only difference is that the tissue Doppler is a Doppler based. While MPI, we talk about it, but I don't think many use it. And then there's fractional area change, theoretically great, but has its own limitations. And you have the pluses and minuses, which I put over there in terms of the technique itself and in terms of other variables which come in. And what really stands out as far as TAPSE is concerned is the reproducibility, and that is not just TAPSE, even the tissue Doppler also. But when it comes to FAC, it is not so great. And then at the other extreme, you have the 3D RVF. So the RVEF, came up a couple of years back, with a lot of hype, but still it's not made much headway. That's because of the technical issues, the quality of the images. But still, if one does get a good image, it's nothing to beat it. But somewhere in between, there is strain over there, and that's where I'm going to focus upon. Now let's look at the RV itself. So what are the diseases associated? So you can broadly sort of classify it as something like a pressure overload condition, a volume overload condition, and then you have the cardiomyopathies where the muscle itself is affected. So the pressure overload is pulmonary hypertension, you have the valve stenosis, the artery stenosis, and the embolism. And then the regurgitant lesions, and then you have the shunts, and then the high output state. So these are the volume and the pressure overload. The cardiomyopathies are fairly sort of, I don't think you will have much issues in terms of using TAPSE, in terms of many conditions over there. Some limitations, but overall I think much more reliable. But these are the other two are the ones which are a real challenge. So at this point, which one to use? This has always been sort of, plaguing us as to what method to use, which way to go. Should we go back and continue to use TAPSE? Should we look at the newer modalities? So where are we, and how should we go about it? So coming to the right ventricular strain itself. We already gone through this yesterday, so just a brief overview. So what not to do when you're doing RV strain. So you cannot go for a conventional, traditional 4-chamber view. It has to be an RV focused view. And then make sure that you don't get the LVOT, that means you should not be tilting it too anteriorly. Nor should you go posteriorly, you should not see the coronary sinus. And at the same time, you should make sure that the annulus is well within your sector width, and then again the RV free wall also should be well within. So these are some very basic precautions. And if you have it, then you go into the quantification and you put the application and it starts to give the numbers here. So again here, make sure that the region of interest does not go too much below the annulus, nor should it be too high, and then it should have a good endocardial tracing. So again here a problem is we are supposed to be away from the pericardium, but we are not very sort of sure as to how much the pericardium is also influencing it. And also it's very important to keep the RV apex also into it. And if we go correctly, everything goes accordingly, we get this nice picture image. So again, based on the vendor, you will have different layouts, and you get these regional numbers. You get both the free wall strain as well as the ventricular septal strain that is included in the what is called as the global RV strain. And then you have these curves, and again looking at the curves also is very important, and then the synchrony of it. So this in all is how you will end up getting the RV strain. So nothing great about it, it's fairly simple. So we've been doing LV strain, only thing is the software was not there, now it is available. Now the problem starts here. So what are the normal values? So this is a paper which was published in 2020, a simple paper, just a how to do paper, and here the normal value is given. It's a short one, and they've looked at the EchoPac, that is a GE, and then you have the Siemens, that is the velocity vector imaging, and then the TomTec. So you have the RV 4-chamber strain, and then you have the free wall strain, and then looking at the lowest number over there. So that is where the variation is. When you look at the mean, not much, both the 4-chamber as well as the free wall, but the lowest number varies quite a bit over there and very limited here. Now, look at this article. So this has come in 2022, so much more recent one. And what you see here is there are 3 authors who are there in this paper also. They were in the earlier paper and they are in this paper. So now you have again a little bit of an issue. So look at the terminologies. So this time they call it as free wall 3-segment RVLS. So that's really a mouthful, and there is still no, it's just an example of what I'm trying to convey to you, is that there is no sort of broad agreement on what terminologies. Again, 6-segment RV longitudinal strain. So this is an issue there. And look at the studies themselves. Gender, no problem, equally distributed, but sample size is very, very low, except for the last one. So that's the 2021 study, that was a World Alliance. So you have a good number of patients over there. So still the numbers really don't sort of really reflect the general population across. And the ultrasound systems are 3 major ones, and then the software used is the Siemens, and then the GE, and then you have the TomTec, which is the Philips one. And again, the average is again varying a lot, and then you have the lowest number also varying a lot over there. So there are quite a few sort of variations as to what number one should use in terms of the strain, and which should be used, whether it should be the free wall or the GLS itself. Now, this is another meta-analysis. So this comes from Cleveland Clinic. So they combined both, a lot of other studies, and here the numbers are much bigger. And they combined even 3D also. So here the strain values are sort of somewhere similar, but you again see the variation. So it is slightly sort of around that 24, and then you have the free wall strain around 28. And then they also have mentioned about the septal strain. And then you look at the 3D also, slightly lower, but again some numbers are being established here. So this is again a little sort of more comprehensive when you compare it to the previous one. So this is more the American side, and that was more the European side. So now if you plug in this column where you want to sort of put in strain. So these are just numbers which you might be debatable as why should you use 28. So it has a plus and minus. You have more standard deviations of almost around 5 for free wall strain. So you can get take it as 28, 24. But I think anything less than 20 is going to be a problem, and that's where the focus should be. Very important that you have a good window. But what an advantage is going to be about strain is that it is angle dependent. No, there is no angle dependency compared to the other parameters, and it provides both regional as well as global information, and also reproducibility is quite good. So the load dependent is a bit of an issue, and compared to the others it is relatively less, but again it is still there. So this sort of reflects as to how we look at the RV in terms of both the health as well as in terms of heart failure. So on one side you have a very sort of at peace heart which has got not much of work to do. It is at peace. The workload is not much. The output is good. But on this side, heart failure sets in, and then all the protective mechanism starts to kick in. So the peripheral circulation starts to bring in its own constriction. Then you have, if there is hypertension, if there is aortic valve pathology, now the load on the LV starts to increase, and then there is LV stiffness, contractile impairment, and then you have, if there is an additional mitral valve pathology, it makes it even worse. And then this sort of passes on to the left atrium, and then again you have left atrial changes in terms of stiffness and all the compliance issues. And finally, the whole thing sort of backs up right into the RV, and the RV has to face this in terms of the pulmonary pressures. So this is manifested as increased afterload, and how does it manifest? You have reduced strain, and then you also have contractile dysfunction. So what are the challenges of right ventricular strain? So this is where the problem is. So here we have vendor variation. So we have different imaging companies, and it's very important to have a good frame rate. Again, there are no standardized terminology, so this is an issue. So which measurement to use? So right now the recommendation is to use the free wall strain and not the global strain, which includes the septum, because it also includes fibers from the LV. And published data. So how much do we sort of rely on the previous studies? So these have been done on apical 4-chamber views, not the RV focused view. So is it really reliable? And again, earlier it was being done with LV software. So now we have a dedicated RV software. So how reliable is the old data? So, and then the studies themselves, they are limited, and in terms of numbers also. And there is no data above 60 years of age, and pediatric is even sort of scarce in terms of normal ranges. And again, challenges, you have only one view, and then the echo window is always a challenge compared to the LV. It is thin-walled, tracing is a problem, and then you have the ventricular septum, which has got mixed fibers, and then it is load dependent, and heart rate is also an issue, and you have to have reasonable sort of heart rate, at least not tachycardic, and arrhythmia doesn't work. And again, there is a gender difference also. There are many sort of variables as far as strain is concerned. So these are the challenges. Now, what about the LA strain itself, the RA strain? So how much of its relation? We still don't know. The RA also, the right side is a low pressure area, so how much does the RA sort of affect the RV? We still don't know. So it would be good to look into the RA strain also, and what is its relationship to the RV. So now the clinical applications. So where are we in terms of clinical applications? So here is a nice sort of summary as to how we should sort of look at RV strain and how we should go about doing it. So first and foremost is heart failure, irrespective of what it is. So it is a good predictor of the adverse events, death and rehospitalization. Cardiomyopathies, any type, it detects subtle RV involvement, which is not detected by other methods of RV parameters. Myocardial infarction, especially in RV infarction, again, it is very good predictor of MACE, and then in pulmonary hypertension is superior to TAPSE. So if you have RV strain, it is much, if you have TAPSE, use this because it's got a good, especially you can use it as a good predictor. TR also, it is useful. Again, it's a good predictor, and congenital heart disease, especially in TOF, there's a lot of data on it. Now, when it comes to looking at the strain itself, so you have the normal strain, and then you have the mildly reduced, and then you have the severely reduced. Again, it's not just numbers over there. You start looking at the tracings over there, and then also you can look at the peak points also. You can see that the last one, severely reduced, the peaking of the strain occurs at different time points here. So that's also very important. So you're looking at not just what the absolute number is, you're looking at the curves itself, the shape, and then also the time points where it peaks. Now, when you start looking at the RV strain itself, so this is how it starts to look. So you look at the pressure overload, the RV strain comes down, but with volume overload, it is still sort of maintained, but in cardiomyopathy, again, it is down. So you have these variations in terms of different pathologies. Now, as a predictor, so there is in terms of heart failure with reduced ejection fraction, how can we use RV strain? So there are a lot of studies here, compiled here, and looking at both retrospective as well as prospective studies. 15% is what the number keeps coming. So every time you're looking at now the RV strain, the free wall strain, use this number of 15%. Anything less than 15%, the patients are going to have more events. Now, what about the heart failure with preserved ejection fraction? Again, there are a lot of variations in terms of numbers. You have 24 the highest, and then you have 14 as the lowest. So there's no optimal sort of what is the standardized cutoff here. So as far as the preserved ejection fraction is concerned, so not much over there. Now, what about when you compare it with the LV itself? So when you look at these various sort of regurgitant lesions or stenotic lesions, not much of sort of value over there. So there's a lot of variation, but free wall strain again stands out as far as the heart failure is concerned, and in terms of how the outcome is going to be. But when it comes to LV, there are 3 studies which show that RV is much better than the LV here. Now, one of the earliest studies came from Mayo Clinic, and again here they looked at the strain as a predictor of heart failure and death, and here using the older software they came up with free wall strain as a better one, and again the cutoff was around 12.5. So the more and more lower you go, so that means more and more adverse events your patients are likely to have in terms of the disease progression, in terms of the the RV failure itself. Now, what about pH itself, a predictive value? Again, 2 studies tells us that not just look at the numbers, look at the shape of the RV curve itself, and then how long it takes. So we are going to look at it very carefully, and then you can also use it as a monitoring parameter. So if it starts to show improvement, that means there is, in one study they showed that for a follow-up of 4 years, the mortality started to come down. So you can use it as a monitoring parameter also. Now, in valvular heart disease, it's mixed. So just a brief sort of overview. The TAVR, SAVR, they have looked at it. Not much of really sort of decisive sort of opinion over there. Now, when it comes to the echo and CMR, what's the comparison? So do not use the same values for what you see on echo in terms of RV strain and the CMR strain. So there is, again, this study showed that you cannot use it. They are 2 different entities. Now, looking at the time points itself, so you have what is called as mechanical dispersion on the RV side. So if they occur at different time points, if the distance is more as they sort of disperse, that means that these are patients at risk of ventricular arrhythmia. So again, you have additional information just by looking at the different time points where they peak. So one can sort of stratify them and look at the pattern and say that these are patients at risk of ventricular arrhythmias. Now, the RV strain, again, looking at the shape itself. So this again tells us as to how is the RV behaving. So the first one, the pattern 1, you can see that the synchrony is there, and the RV strain is not that much reduced. But when you come to pattern 2, see the flattening, how the RV strain happens. So there is a lot of extension of the curve. It flattens, it goes into diastole, and here the patient has got more significant pulmonary hypertension, but the heart failure is there, but it's not that bad. But it is the pattern 3 that should be worrying all of us. So here what happens is there is a very low strain, and there is a very prolonged sort of coming back to the baseline here, and these are patients in advanced heart failure, and they don't do well, and they have a very bad outcome. And this is the survival curve, which shows that looking at the shape of the curve itself, you can you can predict as to how long they're going to live. So you can see that the pattern 3, the last one, these are the patients who have a very low sort of survival. So we have these issues. So what is coming as far as right ventricular strain is concerned? So as always, 3D is there. So advantages, no out of plane motion. So you have the early reports saying that free wall strain, again emphasizing it is much better than the 2D. And then limitations still in terms of frame rate is still an issue. And again, quality of the image is very, very important. And of course, a lot of data is needed, and this is where it is as far as 3D strain is concerned. Now, this is just hot of the sort of the kitchen here. So this is just a few days back. It has been published, and this is coming up in the JACE the journal. And these are people who are sort of really valued people. You have Greg Stone over there, Anthony DiMaria. So it's a very heavy sort of study over here. And what they've done is they've just taken one 4-chamber view, and they've looked at the conventional parameters using AI. And they found that it had got great sensitivity as far as AI is concerned, and that includes even the strain also. So in future, this is how it is going to be, just one capture of the right ventricle, and hopefully this gives us information and gives us us more sort of insight into how in terms of prediction as to what will happen to the patient. So in conclusion, what I would like to sort of end is that RV quantification is less of a black box. Earlier we did not know what was happening inside, but now we are a little aware and we are able to understand the input that is going in and the output that is coming out. Many challenges are there, but 2D RV strain can be done, and it is still, it's got data which sort of strongly says that it is useful. It has got great reproducibility, relatively load independent and angle independent. That is the greatest advantage. And then it gives you global and regional information. Availability is something I think it needs to have more penetration, just like the GLS of the LV. Ease of use, it doesn't take much time except for the acquisition. You need to have a good window. It's got a very high predictive value as the data shows, and compared to the other parameters, whether it is TAPC or FAC or any other parameter, this is superior and should be the preferred choice. So don't just look at the absolute value, you also need to look at the shape, the peak strain timing and the mechanical dispersion. This gives you additional information, and the value is sort of very focused right now. Pulmonary hypertension patients, CAD patients, the RVMI, any type of heart failure patients, cardiomyopathies, looking at severe tricuspid regurgitation and congenital heart disease. So it can be used in clinical routine, but it should be used with caution, and it complements other parameters, and we continue to use it till additional data comes, and we see 3D AI in the horizon, and let's see what happens in the days to come. Thank you.